Good morning, everyone. Afternoon or evening, depending on what part of the world you're in. We are going to go ahead and get started at the top of the hour here. So I want to welcome you to Persyst Grand Rounds, which is an online series of lectures hosted by Persyst, covering topics related to advanced EEG analysis for improving outcomes in both neurocritical care and epilepsy monitoring environments. I am Marie Terrell, Director of Product Management with Persyst, and I am here to introduce our speaker and topic for today's Persyst Grand Rounds. Next slide, please. Through our customers, we understand the importance of investing in the EEG community through education, where expertise and knowledge can grow towards the utilization and implementation of EEG and quantitative EEG. The goal of Persyst Grand Rounds is to provide a platform for those with clinical expertise on topics of advanced EEG analysis as a way to connect with you, the broader community, to share their expertise and knowledge so that we can all learn and grow together. Each online lecture features an experienced epileptologist, neurophysiologist, or neurosurgeon presenting on a topic of their choice as it relates to EEG monitoring and analysis. You can visit persyst.com/grandrounds to keep up to date, and the schedule is subject to change. Okay, next slide. The opinions and viewpoints of each speaker are solely their own and do not represent Persyst or any other commercial entity or commercial interest. Speakers are not required to include Persyst, its software, products, or services. The content presented was not prepared or edited by Persyst, and Persyst is not providing any form of compensation. Okay, and finally, what we've been waiting for. There will be time for questions after the talk. You have a little Q&A box at the bottom of your screen, which you can write your questions into. We are recording this webinar, and a copy will be made available to all of the participants. And here we are. I want to welcome our speaker today, Dr. Susan T. Herman. Dr. Herman is going to speak on how and why to integrate electrical source imaging into your practice. The learning objectives are: 1, recognize the indications for electrical source imaging in epilepsy, including high-density EEG. 2, optimize ESI acquisition and analysis using clinical toolboxes. 3, develop an ESI program that meets the needs of the EEG lab and clinical epilepsy team, including workflow and reimbursement. And about Dr. Herman, she is a professor of neurology and the vice chair of clinical affairs for the Department of Neurology at Barrow Neurological Institute. She is board certified in neurology and the subspecialties of epilepsy and clinical neurophysiology by the American Board of Psychiatry and Neurology. Dr. Herman is the president of the National Association of Epilepsy Centers, co-principal investigator with the Epilepsy Learning Healthcare System, and she is the past president of the American Clinical Neurophysiology Society. Dr. Herman's expertise includes the treatment of drug-resistant epilepsy. She is a national leader in electroencephalography, technology, and interpretation, including video EEG monitoring for epilepsy, continuous EEG monitoring in critically ill patients, and high-density EEG and source localization. She is a member, excuse me, of the American Academy of Neurology, the American Clinical Neurophysiology Society, and the American Epilepsy Society. Dr. Herman earned her medical degree from Columbia University, Vagelos College, I'm not sure if I'm saying that right, of Physicians and Surgeons in New York City. She completed her neurology residency and a fellowship in epilepsy, clinical neurophysiology, and neuroepidemiology at the Neurological Institute of New York at Columbia Presbyterian Medical Center. Her clinical research focuses on epilepsy and EEG. She has served as a local principal investigator for multiple clinical trials of new epilepsy treatments and has also studied the treatment of subclinical seizures in children with cerebral malaria and the development of epilepsy in patients with progressive multifocal leukoencephalopathy. She is currently a co-principal investigator of the Epilepsy Learning Healthcare System. I already mentioned that, but I'll say it again: a network where families, community members, clinicians, researchers, and healthcare leaders can collaborate to improve care and outcomes for people with epilepsy. So with that impressive background, we welcome you a second time to Persyst Grand Rounds, Dr. Herman. Thank you very much. Please take it away.
Thank you so much for that great introduction. I will first say that it's a little out of date, so I am past president of NAAC, and I am no longer the co-principal investigator, but a participant in the epilepsy learning healthcare system, and I have ceded those responsibilities to really exceptional people. So what I'm going to do today is to talk about the how and why of integrating electrical source imaging into your practice or your EEG laboratory. I know that there's already been a ESI lecture in this series, but it was very much focused on the theory behind ESI and why you should depend on the results. And those of you who know me well know that I was a classics major. And so I am not going to talk to you at all about the theory of ESI because I can't. I'm going to talk about understanding some of the clinical uses of ESI and how to integrate it effectively into your clinical practice. And I'll be happy to take questions at the end. I first have to say that none of this lecture would be possible without my colleague, Stephen Foldis, who's a PhD, who does all of the modeling work and develops the head models and actually does a lot of the generation of the source localization models. And we go over all of those together. And we would not have a high density EEG program without his involvement. Okay, so these are my disclosures. None of them are actually relevant to this presentation. So just an outline of my talk. I'm going to talk a little bit about why ESI and why it should be a part of the pre-surgical evaluation for patients with drug-resistant epilepsy. I'll run through the practical steps of ESI with a focus on what are the options for tools that can be used for performing some of the steps of ESI? And then finally, I'll present some use cases and how we have incorporated them in our own program into our pre-surgical planning conference. So by and large, ESI is used for advanced localization of epileptiform activity, interictal epileptiform discharges, and seizures. So for many, many years, the focus has really been on visual review of interictal epileptiform activity in a 2D EEG, two-dimensional EEG, and not really thinking about how we would localize this in the 3D structure of the brain. And although we all know that the spikes are not generated always from the region right under the electrode that we see the maximal electronegativity in, that's often the assumption when we're looking at things in 2D. It's very hard to actually go from an EEG, as you see here, to a 3D representation of what the source of that epileptiform activity is. Many of us use voltage maps to help with some of this, but that still does not really tell us where the activity is coming from in the brain. So this simple localizing the maximal electronegativity, either by amplitude, as you would see here, or by a voltage map on the surface of the brain, really doesn't give us the entire answer to the question. And the best that we can do in terms of resolution of where the localization is at the regional or sub-regional level. A better way would be to actually be able to tell exactly where the seizures come from within the brain. So as you see here, this is a dipole model demonstrating the solutions for a large number of interictal epileptiform discharges, where they come from in the brain. And this purple one in the middle is an average of all of that activity. And then we can use the dipole localization. This MRI is split so that we can actually look at the direction of the dipole in 3 planes. We know that the dipole often localizes deeper than the actual source on the surface, but we can project this dipole down into the region of the cortex where the dipole, where the seizure activity or the epileptiform activity actually begins. So we can see here, if we do it in a coronal view, we can see that it's sort of towards the middle or inferior temporal lobe. And we can see on the other view that it points to the anterior to mid-temporal lobe. So here we have a pretty good localization at the sublobar level of where this activity actually begins. And we can see this in co-registered to a anatomical picture that allows us to do pre-surgical planning. So this is a quick overview of why we might use electrical source imaging. It's used most often for identifying the irritative zone. So this is interictal epileptiform activity. And we all know that this is sometimes not synonymous with the epileptogenic zone or the region where seizures begin. And so there is some additional work looking at using electrical source localization techniques to identify where seizures actually begin by doing the same processing on seizures. And we can do this most often for pre-surgical evaluation, but it also has some potential uses for non-invasive brain stimulation, like transcranial direct current stimulation and transcranial magnetic stimulation, which have shown some preliminary efficacy for decreasing seizures in patients with intractable epilepsy. So this is another reason why you might need to know exactly where in the brain the seizures are beginning. ESI can also be used to help identify eloquent cortex by using it in combination with evoked potentials, but I'm not going to talk about that today. So ESI has two main components. The ultimate goal is to solve the inverse problem in EEG, which is figuring out from the scalp distribution of electrical activity where that activity originates deep within the brain. There are two parts to this. The first is generating a head model, which is if we put a known source in a virtual brain space, what is the head model that would be generated by that virtual brain source? So that's the forward problem, and that's relatively easy to solve computationally. The more difficult problem is actually doing the reverse, seeing what the scalp activity looks like and going back and figuring out where it comes from within the brain at a particular point in time. And there are many, many solutions that could be done for this inverse solution. And I'll talk about some of the pros and cons of different techniques of this as I go through the steps of monitoring. Now, ESI is one of the simplest things that is underutilized in epilepsy pre-surgical planning. This is not impossible to do, and yet very few epilepsy centers do a lot of this. So when we did a survey of centers in NAC, less than 50% of the centers do electrical source imaging. Many of them do it on low density EEG and only in certain kinds of patients. It is certainly not a widely adopted technique. And I think there are several reasons for this. There's often inadequate education and fellowship programs to tell people how to do this, both physicians and technologists. And even when it's done within a center, so our center does quite a number of high density EEG source localization studies, but there are only certain personnel who actually do this. So we have certain EEG techs who can do it and certain attendings who read the studies, partly because it's very complex and not everyone wants to learn how to do this. But I think the problem that people don't really understand the concept of this is a very large issue in why this is underutilized. It's also very technically demanding. You need special software to do the ESI analysis. We acquire all of our ESI studies as a high density EEG, which requires specialized and expensive equipment and software packages. And so that can sometimes be a barrier to ESI. Much less so because now it's integrated in more and more software packages that are available for clinical use. The source localization software packages are relatively complex. It takes some time to learn how to do them and to use them effectively. There are a variety of software packages that are available. Some of them are FDA approved and can be used for clinical use versus non-FDA approved, which means that there are restrictions in whether you can use this outside of research applications and whether you can actually bill for the services. Unfortunately, the ones that are even the ones that are FDA approved may be very, very complex, and they are often not optimized for clinical use. So a lot of the things that we would do very easily in commercial software packages, like change montages or develop different views of the EEG or do spike and seizure detection, are not optimized within the commercially available ESI packages. So it does often require someone to help you put together different packages. For example, we do all of our acquisition in one software package that is an ESI package. I read all of the EEGs in a clinically available, we basically turn it into an EDF format. I do my spike detection in a clinically available software, and then my PhD transformed that back into marks in the ESI software because I refuse to use the very clunky ESI software. So depending on how good your personnel are, you may actually find that you need several different solutions. And then finally, many of the ESI software packages are relatively expensive and somewhat restrictive in terms of licensing. And so that significantly increases the cost again. The next issue is image acquisition. You need to get certain kinds of MRIs in order to do optimal source imaging. I'll talk more about this later. The image processing is something that I think a lot of epileptologists are not completely comfortable with. And you may need other radiologic or PhD staff to help you do some of the image processing. It takes a long time to read an ESI study, marking every individual spike and marking the peak, and then doing the source localization and the image processing is not a short amount of time. And this translates into the fact that reimbursement for ESI is really inadequate for the amount of time that is required to actually do the test. And I honestly think that's probably the biggest barrier to clinical use, is that it's a very time-intensive process for which we are not paid. Unfortunately, in order to apply for a new code through CMS, you have to have a group of at least 50 people who are doing a test in a very similar way. This is done so infrequently and in such variable methods that we have not been able to come up with a process to apply for a new code. And so some of what I will call for today is for more people who are doing this and doing it in a clinical basis, form a working group to standardize the way that we do this so that we can apply for new codes that will actually pay us for the work that we do. It's probably not appropriate for me to say in a lecture like this, but it's the truth. So why are we going to add ESI to our pre-surgical evaluation? There was a systematic review that was done back in 2019, published in Clinical Neurophysiology, that reviewed almost 2,000 papers on magnetic and electrical source imaging. They ultimately included just 11 in the review that had adequate quality and followed the patients to be able to tell whether ESI or MSI actually changed the outcome of the patient. So 8 of these papers were on magnetoencephalography. The other 3 used high resolution ESI. So these are the 3 studies. All of them were prospective. They included both adult and pediatric patients, and they all used high density EEG with between 128 and 256 electrodes. And I'll talk later about why that's important and why you should think about using high density EEG. Overall, using a rating scale for the quality of the study, they used the Quadus 2. All of the studies were poor. They suffered from significant selection and study flow bias, and so they did not have a high rating for level of evidence, and also suffered from underreporting of the outcome. They didn't have outcome data on all of the patients. However, these are the 3 studies, 2011, 2014, and 2016, using over 100 patients, sometimes with follow-up for at least 1 year. One of the studies only followed patients for half a year, but these patients had good post-surgical outcome. They looked at patients who underwent epilepsy surgery, and they looked at the outcomes of Engel 1, and this one study that had shorter outcome looked at Engel class 1 and 2. So this is a pretty standard setup for evaluation of a diagnostic test, similar to studies that have been done in magnetoencephalography and MRI and SPECT, et cetera. And to cut to the chase, good surgical outcome were more likely concordant than patients who had a poor surgical outcome. So if you resect the volume that was identified by source localization, patients had a better outcome, or this was associated with a better outcome. And overall, for the high resolution or high density EEG, the results were a sensitivity of 87% and a specificity of 61%. And this is actually very similar to, as you see, MSI, magnetic source imaging, which many of us think of as a very useful localizing technique for drug-resistant epilepsy, but also not outside the range for things like SPECT and for MRI, where the sensitivity and the specificity are usually in the 60% range. So this is definitely not perfect, but probably equivalent to the other diagnostic tests that we use every single day to identify seizure foci. This is a second meta-analysis that was done by Sharma. They looked at 25 ESI studies, more than 500 patients, and the sensitivity of co-localization and good outcome was 81% sensitive, and the specificity was a little lower at 45%. But importantly, the diagnostic odds ratio, if you actually found a focus on electrical source imaging, patients were 4 times more likely to have a good outcome than if you did not find a reliable focus. Another group looked at the diagnostic added value of source localization. So this group took more than 80 patients, adult and peds, who were doing pre-surgical evaluation. They did both low density and high density source localization, developed with an individual head model that was based on the patient's own MRI. And they had intervention in their multidisciplinary team meeting where they would present all of the data except the electrical source imaging, and they would make a decision about what they were going to do, SEEG, resection, where they were going to resect, et cetera. And then they would give the results of the ESI study to that multidisciplinary team and rediscuss it and determine whether anything would change because of that discussion. So a pretty good way of looking at the incremental value of ESI compared to other tests that are available. And they found that ESI often provided unique information, non-redundant information, and frequently resulted in a change in management plan. So here's just a summary of where the patients had their presumed epileptogenic focus. Not just temporal, but they also looked at extratemporal and several patients who had multifocal abnormalities. About half of a little more than 2/3 of their patients had epileptogenic lesions on MRI. But often those lesions were very large and they needed the ESI to make this more localized. And they found that ESI changed management in 28 of their patients, so 34% of all of the patients who were presented. In 24, it changed the invasive recording plan, so it actually caused them to add or subtract stereo EEG or other intracranial electrodes from the implantation plan. And in 4 patients, they actually had thought they were not candidates, and they decided based on the results of this that they could go to intracranial recording. And one patient where they had decided that they weren't going to do it, and they added ECOG to the plan. The concordance was in this study was about 74%. So again, incremental value from doing electrical source imaging. Interestingly, the low density EEG was also really helpful. So the high density EEG was done in 23 patients, a low density EEG in 16. And these, in this study at least, were not significantly different, but I hope to convince you that high density EEG does have some value. All right, so we'll change gears now and go from why you should think about doing this into how do you actually do it and what are the steps. And there's multiple steps in acquisition, and Dr. Foldis and I play a little game called Does It Matter? Like, does it matter if the electrodes are in the right place? Does it matter if you digitize them? Does it matter if you pick this kind of spike or that kind of spike? And so all of these things are actually quite important, and understanding the pros and cons of doing these steps versus not doing them is actually quite complex. The first step is electrode positioning. So where are you going to put electrodes on the head, and how many are you going to do? I would recommend that at least you do the 1020 system plus the expanded subtemporal chain of electrodes. But the sensitivity of, or the utility of this increases significantly when you go up to 64 electrodes, and then a little less advantage for doing more than that, but covering more of the head is probably more important above 64 electrodes than actually just having more electrodes that cover the same part of the head as we do with standard EEG, and I'll talk more about that. The second is, how do you figure out where the electrodes are? Do you digitize them using a digitizer solution? And we found this to be extremely important, and that our electrode localization and where it fits on the head in terms of the 1020 system is not as good by our techs as we thought it was. And our techs are really good, but knowing exactly where they are, they can be off by a centimeter or more, and knowing that is crucially important for source imaging. How do you select intra-epileptiform discharges? And we'll talk more about that as well. How do you do the image processing? Developing the forward head model, so the forward solution, and which model you actually use. And then how you do the source localization itself. Do you use a dipole method or a distributed source localization method? So I'll go through all of these steps in probably excruciating detail, and you're more than welcome to ask questions about this at the end. And then finally, how do we co-register this to imaging, and how do we display this to the other physicians so that they can actually incorporate this into clinical care? So the source localization software, there are some packages that are EEG only, some that are optimized for EEG plus MEG, some that do EEG and MRI and also incorporate other neuroimaging studies like PET and CT scans, etc. And as I mentioned before, some of these are open source. They're generally not FDA approved. The advantage to these is that they're free or low cost, and they tend to have a lot of features because they're developed by a large group of people who are constantly adding toolboxes, etc. However, they are often less user-friendly for people like me who's experienced EEG, but really doesn't want to go back and get a PhD in physics in order to read my EEG. And so the open source packages are great, and there's been a lot of work done in them, but they're not optimized for clinical use. And so it's even more of a time sink than using some of the commercial software. So proprietary is often single format. It can only read 1 or 2 types of EEG. Others will allow you to read EEG from a large number of vendors, and I would recommend that you look for a package that allows that. They're often more user-friendly, and they have some of the features that we would expect in commercial EEG, but unfortunately, they're not simple, and they don't easily do a lot of the things that we would expect. It's not easy to transform montages, for example, or to do spike and seizure detection. And then the real downside of these is that they tend to be very expensive. And because a lot of cost goes into the development of these, the licensing is often very restrictive. So I talked a little bit about electrode placement. So your best bet is to completely cover the head and have electrodes that are evenly spaced, but we all know that that's not the case for the 1020 or even the expanded 1010 system. When you do this complete head coverage, you're optimizing the chance that you'll be able to see both the negative and the positive poles of the dipole, both the electronegativity that we're used to seeing, but also the positivity, which often, points down below the temporal chain. And so including more of the head surface is a good way to improve your dipole localization. For patients with temporal lobe epilepsy, you really should use the 1010 subtemporal chain electrodes that are recommended in the IFCN recommendations for expanded electrode placement. In some cases, you can put additional electrodes around the area where you think the seizures begin. And for example, in patients with frontal lobe epilepsy, you might just put additional electrodes over the frontal lobes. But these do produce some bias because you're basically loading the localization a little bit towards the frontal lobe, so you're more likely to get slightly misplaced dipole results when you do this. So if you're going to place electrodes, it's better to place them pretty evenly over the cortex. And then finally, the spatial accuracy is clearly better the more electrodes you put on it. Significantly increases by 64, increases a little more to 128. We haven't done a lot of 256 so far, but there's potential increased yield even with that. So here are the 3 systems. So this is the extended 1020 system using the subtemporal chains. So this would be the minimum that you should use for electrical source slit imaging. Going up to 64 or 74 is the modified 1010 system. So you can see the coverage would be much better. And then the 10.5 system that has been described by Oostenveld accommodates up to 345 electrodes. This is actually a representation of that. But again, if you're not going much down below the subtemporal chain, this may give you some increased yield or accuracy, but it's probably not going to improve your localization much in the temporal lobes. So here's just an example of how helpful this can be. So this is a standard density EEG, and you can see the epileptiform discharge distribution. But when we look at this subset, this is just these electrodes down here, the same region. You can see that this is now much more wide, seen in many more electrodes. And so you get a much better representation of the electrical field. And this is always done using a voltage map at the same time so that you can see what the voltage of the activity is as you're looking at your spikes. Okay, so how do we acquire EEG? So we use high density EEG, 128 channels. We use a cap to place the electrodes because you can't really do 128 individually. All of our patients are partially sleep deprived, which we know increases the yield of interictal epileptiform activity. We do 2-hour recordings to make sure that they get into stable sleep. And then we do a lot of work to avoid artifact, because this is the other big issue in high density EEG, because there's so many electrodes, it's really easy to miss artifact or not correct it during the recording. So having good electrode impedance, so you avoid 60 hertz artifact, having the patient relax to decrease muscle and movement artifact, and then identifying bad channels, even if you can't fix them all. Because if you do have a lot of artifact in your study, then you have to remove all of this post-processing and in post-processing steps. And so it makes sense to try to take a little extra time and get a good quality study at the beginning. We acquire our studies with video because we've actually found that we have a reasonable number of seizures that occur during these recordings, and we use a high frequency sampling rate of 1,000 hertz. So here are just some of the examples of high density EEG and some of the pros and cons of them. So these caps are usually available in standard EEG montage localizations, but also expanded. So here's a 128 channel. But you can see that we actually don't get a lot more recording in the lower parts of the head. So this is one of the limitations of caps that really just do the temporal chain and above. Some of the caps actually go down onto the face, onto the forehead, onto the back of the neck. I used to use a cap like this in my old institution. I would highly recommend it, but they're a little more difficult to use. And you can see here what the montage is that we use and what the distribution of electrodes is. Then we co-localize, localize the electrode positions. We do digitization using a handheld digitizer. You can also use this using an infrared tracker. In my old institution, we used a photogrammetry system, which takes pictures of all of these electrodes from multiple angles and then solves for the location of the electrodes. But this process allows you to precisely localize the electrodes compared to the MRI. And so we identify certain landmarks on the EEG and landmarks on the MRI that allows us to overlay these electrode positions. And this is an example of that. So we then co-register where the electrodes are in space, where to where they are on the head, where they are on the MRI. And this is an example of that co-registration process. For neuroimaging, I mentioned that there's maybe some changes that you need to make in the way you acquire MRIs. If you're doing individual head models, you have to acquire individual high resolution MRIs for patients. The recommendations are that you acquire at 3 Tesla, that you use 1 millimeter slices, and that you use an image acquisition that is likely to show high gray-white distinction. So T1 is adequate but not optimal. NP-RAGE or SPGR are actually far preferred, and you should make sure that those are done before the patient gets any contrast because the contrast will interfere with the gray-white delineation. So for our group, we actually work with our radiology group so that all of our epilepsy protocols actually include this sequence, high resolution sequence that goes from the top of the head all the way down to the chin of the patient, and that goes from ear to ear. And those are areas that are commonly cut off in standard MRIs, because who needs to see the top of the scalp in standard MRI? But it's really, it makes a difference for localization. Dr. Foldis found that losing the top 2 centimeters of the MRI can lead to errors in your source localization by 1 centimeter or more. So you may need to work with your neuroimaging group to actually get this. Now, you don't need to do this. Most of the packages include a template MRI atlas, and you can do your source localization using that template. But we have found that individual head model is much better, and then you can compare your localization to any abnormalities on that individual patient's MRI. Doing the MRI segmentation, the good packages have a lot of automated features that do some of the segmentation for you, but then you can also correct them manually. And here's just an example of, identifying the gray matter versus other areas of the brain that are available in all of these packages. Okay, once you've done that, then you can construct the volume conduction head model, often called the lead fields matrix. This is the solution of the forward problem. What would the activity of the brain look like if you put a source of electrical abnormality somewhere deep in the brain? These are pretty variable in terms of how complex they are. So there are the models are based on the actual conductivity of the tissues that are in the brain: white and gray matter, CSF, bone, muscle, scalp, air. These are all of the things inside the head that have different electrical conductivity, and also incorporates the shape of the tissues. The most simple models are spherical head models. They're just simple circles or spheres, either a single sphere or multiple spheres. Probably the 3-sphere model is the most commonly used. But much better is to use anatomically realistic head models, either the boundary element model, which is what we use, and this measures the conductance variation between different tissue planes. So when you go from white matter to gray matter, where you go from white matter to CSF, et cetera, what is the change in conduction that occurs, as opposed to the finite element model, which is a little more time consuming, that basically kind of aggregates adjacent tissue and measures the conductance or assumes the conductance of those tissue groups. And this model, it can be used particularly in patients with skull defects to limit some of the errors that can occur when there's a hole in the skull. So as I mentioned, you can do this very simply using an atlas-based model, or you can have a individually derived patient-specific model, which is what we use in our center. Next, how do you select interictal epileptiform discharges? It's really important to identify each spike type and to remove any artifact that is occurring in the EEG at that time, so that those channels are not influencing the source model results. We separate our spikes into types by what the spike looks like, what the duration is, what the morphology of the spike is, and by where it is located on the head. What's the localization? Is this an F7 spike? Is this an FD9 spike, et cetera? It's great to be able to have the voltage field at the same time, so that you can actually look and see if the spikes that you're putting together in the same group are really similar. Then we average the results for each group. We like to use at least 5 or 10 spikes, but there are different things, that you would put into the consideration of whether you need at least 5 or 10 spikes, including how similar are the spikes, how high amplitude are they, do they have the same morphology or not. We then align these interictal epileptiform discharges at the peak. Aligning them at the peak improves the signal to noise ratio by the square root of the number of spikes that you see. So looking at the peak really improves the signal to noise. Averaging the spikes improves the signal to noise. And taking the peak is where the signal to noise ratio is the highest. So you can localize the spike at the peak. However, we know that that's probably not where the spike begins. It would be nice to be able to look at the onset of the early components. Unfortunately, spikes are quite variable early in their generation and may not be clearly distinguished from the background. So oftentimes we'll take 50% of the rising phase to determine where the localization should be done. So the peak may not represent the onset, 50% of the rising phase may be better. Or you can use the first localization that meets some adequate fitting statistics, which is too complex for me, so we don't use that. Actually, Dr. Foldis developed a sort of a analysis of the spike over the entire time of the spike, from the onset to the peak, and we judge whether the spike has propagation or doesn't have propagation. And so we can look at the early components and see whether those are helpful, see whether there's significant propagation. If not, then we look at the peak because that has the best signal to noise. So here's just an example of a bunch of spikes. These are very similar in terms of what they look like. We can look at the voltage field of those spikes, and then we can look at the average. We then do our source localization using the equivalent current dipole model. This is probably the result that you guys are most familiar, and we assume that the epileptiform discharges as a single point source, and that usually the solution to this is a dipole that is deep to the cortex, generating the source as you see here. And the dipole indicates direction. So this purple bar, which represent the average, is kind of like a flashlight. So the actual source of the activity is probably from this region within the beam of the dipole. So we assume that it comes from the cortex out here, and it probably comes from a region of cortex rather than a very specific area. So this is a cluster of dipoles and the average dipole solution. We look both at the number of spikes that are averaged together, how tightly the cluster is clustered, actually, whether it is all giving similar results, which is probably true for spikes that have similar morphology and duration, versus more widespread. There's actually a very tiny, not well seen red line in this, which is the confidence interval of this average, which can also give you some assurance that you're looking at spikes that are similar. When you use multiple dipoles, this is often very difficult to interpret. And so most of the time we try to fit this to a single point source, even when we know that sometimes an individual spike may come from adjacent areas of the cortex. This is the propagation or not, an example of this. So this is a spike that did have propagation. So this was the peak. Oh, sorry. This is the wrong figure. Sorry. This one over on the right-hand side of the screen shows you the propagation of this spike from green is the red is the earlier and green is later. So you can actually see that this moves a little bit over the course of the spike, gives you slightly different results of the dipole. This is actually two different spikes that are tightly, from similar but not exactly the same regions. You can see that the confidence interval is actually much bigger for this red spike because we had fewer average spikes in this, so the confidence interval was bigger. And this is in relationship to a lesion on MRI in this patient. So fairly close to this region. This is actually a big area of cortex that was encephalomalacic. You can also do current density models. We are playing around with this, but we don't use them often. In this case, the dipole is the source is considered to be a linear combination of dipoles with a fixed orientation. And in this model, you can actually constrain the results to the cortical surface. You get a more realistic view, but it can sometimes be a little misleading. But anatomically, it makes a little bit more sense than the dipole, where you have to assume there's a projection of the dipole to the cortex. This actually shows you the results in relationship to the cortex. And it color codes the results so that the highest intensity source is at the center, and then the edges are a lower color and a little bit less reliable. One of the biggest problems that I have with the distributed current density is that you get to pick what your threshold is. So you can make this result as big or as small as you want, depending on your threshold. And when I talk to people who use this a lot and we say, how do you pick your threshold? They say, well, we just make it as big as we think the source should be, which is not a very satisfying answer to me. This is pretty sensitive to the way that you do your image processing. And especially if you have anatomic distortions, a lot of encephalomalacia or cortical abnormalities. And these are just some of the different techniques that are used for distributed current density. Here's an example of what it would look like. So you can see that this, is anatomically more satisfying. And you're like, oh yeah, this could be from the cortex or from the hippocampus or from the basal temporal cortex. But we've had other solutions that give us, areas that are really discordant from what we would expect from the dipole. And so we do mostly dipole monitoring at our center. All right, so when do we do ESI? When we don't have enough localizing abnormalities on MRI or on EEG. When we have epileptiform discharges that are broadly distributed or bilateral, but they have some focality, so you think that they actually are focal spikes. When your visual EEG analysis is really complicated and you can't figure out from this what the dipole would look like, where the spike actually originates. To refine available information, so if you have a large MRI lesion that is probably not completely resectable, can you actually determine what part of the lesion is epileptogenic? To get more precise localization, ESI can be very helpful with that. Allows you to sometimes tailor where you're going to put electrodes for SEEG. And then finally, just confirming information that you already have from MRI or from EEG. We all know that the more concordant tests that you have, if you act on those, the patient is likely to have a better outcome. All right, so here are just a few cases to run through. This is case one, is a 40-year-old left-handed man. He's had drug-resistant epilepsy for years. His seizures are daily, and his semiology is just headache and dizziness, deep breathing, turning to the right, and then he has a bilateral tonic-clonic. MRI was normal, but was slightly motion degraded. His EEG showed left frontal interictal epileptiform discharges and seizures. And this is his high density EEG result, frequent high voltage left frontal spikes with this distribution of the maximal amplitude. One of the things about having 128 channels is that you get spikes that look pretty similar in wide areas of the montage. And then he also had frequent left frontotemporal spikes with an even broader distribution. So here's some examples of the two types of spikes. So this was spike type 1 in the frontal region, and this is spike type 2, which are lower voltage and have a slightly more restricted field. And then you can see how broadly distributed these are in a 128 channel montage. And you see here as well that these actually have a much broader number of electrodes that are incorporated. These are the fields that are generated by these spikes. And in terms of localization, this is spike type 1. You can see the dipole results for that and the average. Spike type 2, which is similar, but actually projects to the cortex slightly differently. And in this patient, actually, we found that there were two small areas of cortical dysplasia on the MRI. Once we saw these dipole results and went back to the MRI and said, you know, what's going on in this region? It's very clear that the cortex is abnormal in these two regions. And his seizures on stereo EEG came from this cortical dysplasia right here, actually almost exactly in this abnormal area. So the high density EEG made us go back to the MRI and look at it more carefully and actually identify an epileptogenic lesion that allowed us to tailor the surgery. Case number 2 is a 26-year-old woman who has drug-resistant epilepsy. Her seizures begin with anxiety and deja vu, a feeling of being attacked, and then stiffening and sometimes secondary generalization. Her MRI was normal. And in her EMU admission, she actually had 29 subclinical seizures from the left hemisphere that were not well localized, and one focal to bilateral tonic-clonic seizure, again, left hemisphere, but could not really be better localized than that. When we did her high density EEG, she actually had 3 seizures during the EEG, and she had abundant left anterior temporal discharges. These had somewhat variable morphology, so we actually grouped them into spikes and sharp waves so that we could look and see whether these had a different source localization result. And in addition, judge frequent runs of left temporal intermittent rhythmic delta activity that we did not source localize. So this is just an example of the different morphology of the spikes and how hard it actually can be to mark these and to determine whether they're similar, right? So these two look very similar, and these two look very similar, and this one has a similar field, but it has a higher amplitude and a bigger slow wave. So it's not the same as these other two. And so doing the sort of subgrouping of spikes, we need better tools to help us do this, and looking forward to some advances that will make this process of marking and clustering spikes a little bit easier. So here's an example of spikes here and the distribution that we can see in the high density EEG. And you see that there's many more electrodes that are involved. Here's the voltage map of that activity. And here is the source localization results. And the way that we interpreted this is that this is from the sort of the anterior to mid inferior temporal cortex. This is an example of the potential propagation of this spike. So the red is earlier and the green is later. So this spike actually moved a little bit, and the earlier components suggested that the source of the activity is actually more mesial and more anterior than the peak. And so this can be useful when you're trying to decide whether you want to look at the earliest components. You know, this one does show significant propagation, so you want to consider the localization of the early components that may be clinically useful. Now, in this patient, we were also lucky in recording seizures. And so here are the results from averaging these individual spikes in the very early part of the seizure and the slightly later part of the seizure. And you can see here are the early components of each of the 3 seizures, and then just a cluster of dipoles from the later part of the seizure. And this is actually very similar to the localization that we receive for the interictal epileptiform discharges. So they're pretty much the same when we look at the average interictal epileptiform versus seizures. Increases your confidence that the seizures actually begin from the region that you identified on interictal. Next case is a man who had prior VFib arrest, had 2 prior MCA strokes, developed drug-resistant epilepsy, and he had 2 types of seizures that were distinctly different. He had some episodes with left arm shaking and dystonic posturing, but he also had seizures with visual hallucinations followed by head and gaze deviation. And his MRI showed right hemisphere pretty extensive encephalomalacia, gliosis, and hippocampal atrophy. And so, this is lesional, clearly, but the lesion was the whole right hemisphere. His EEG showed frequent cyclic seizures from the right posterior quadrant. And when we looked at his interictal epileptiform discharges, we saw 2 types of epileptiform discharges, one from the posterior temporal region, and I don't have a picture of the other one, but this is the source localization results. You can see a very tight cluster, fairly large area of cortex in the average solution right at the margin of this encephalomalacic lesion that you can see on MRI. So there were 2 different spikes of this type, some that were high voltage and some that were very much smaller, and they had very similar localization. But his other spike type was actually more from the central region, and you can see the dipole localization of that. So this is probably his dystonic hand seizures, with the other one being the site of his visual hallucination seizures. We didn't record any seizures during the high density EEG, but this allowed us to plan his stereo EEG setup. So he had the posterior temporal spikes, and then he had the more central region spikes, both at the border of this big encephalomalacic lesion. He decided to go for deep brain stimulation, I think, so we're never going to know exactly where his seizures begin. And then finally, this is a patient with déjà vu and nausea. His MRI was normal. He had 18 left temporal seizures and rare spikes. His high density EEG showed rare spikes. He only had 4 or 5 spikes, I think, which were quite stereotyped and extremely high voltage. And so we don't have a tight, a very dense cluster here, but we had pretty good average results. And there was, again, propagation of this from the early components, which were more anterior, to the late components, which were more in the posterior, in the back of the anterior temporal lobe. And so we were more confident that this patient did have anterior mesial temporal lobe epilepsy, and planned his stereo EEG accordingly. So for optimal ESI, we really want to be able to do the best combination of computational efficiency and accuracy. So I would recommend at least the 1020 subtemporal electrode system. High density EEG is a lot more work, but I think gives better spatial sampling and better results. We use the boundary element model because it's a little bit faster and less computationally complex. We do the equivalent current dipole solution, but we're playing around to see whether we can see that the distributed current density solution is similar or not, to help us judge the reliability of the dipole solution. You can also do statistical processing to determine the reliability, the goodness of fit of the spikes that we could ask Dr. Foldis about. Limitations, you do need probably at least 5 interictal epileptiform discharges. Recording in the epilepsy monitoring unit would probably be higher yield, but it's complex to keep electrode on the head, high density electrodes on the head for such a long time. We know that the irritative zone may not be exactly where the seizures begin, and so when we have seizures as well, we are much more confident of the localization. The spike peak gives you the best signal to noise, but may represent propagated activity. We want to go as early as we can, as long as we have a stable localization of that. But you need to average a large number of spikes to be able to use early components. So it's not appropriate if you just have a few spikes. Patients who have skull defects or other large lesions, the modeling for this is very, very complex anatomically. And then finally, the dipole solutions and the distributed source solution methods for modeling ictal activity are much less well established than for interictal activity. So that is the end. In conclusion, I would say that ESI is something that anyone who's doing epilepsy surgery should have as in their toolbox for pre-surgical localization. And it should be as routinely used as MRI, INSPECT, and MEG. There are a lot of barriers for routine clinical use, but the biggest barrier we can overcome, and that's education. So thank you
Wonderful.
very much.
Thank you. What a talk. Thank you very much. If you have time for it, we have a few questions.
Okay.
Great. So the first question is, let's see, what is the ESI finding in patients with idiopathic generalized epilepsy? And can it help differentiating IGE from frontal lobe epilepsy with rapid synchronization?
It can be helpful in that, but it really depends on whether you have spikes that have some suggestion of focality. I didn't put an example of that. We do have some examples where we have been able to show that the discharges are really left frontal parasagittal as opposed to truly generalized. If there isn't any focality on the EEG, then I think that the confidence in the source localization results is probably, to my mind, a little bit less, right? I want to be able to see that they at least look a little different.
Yeah.
There's a clinical suspicion that they're focal.
Yeah, that makes sense. Okay. Is it possible to localize non-spike EEG features? For instance, low amplitude fast activity at the start of a seizure or focal slowing?
Yeah, so actually one of our best examples of this where Dr. Polis showed me the results and said, I think this is too good, was a young woman who had like 13 seizures during her high density EEG that had a very low voltage beta signature. And because we were able to actually average so many of the initial beta signals, we had a pretty good signal to noise ratio. And we actually co-localized her source localization results to MRI, and it exactly co-localized to a cortical dysplasia.
Mm.
But you need a lot of beta spikes because they're so low voltage to be sure of the results. And so I think the biggest limitation to a source localization of beta activity is just how many abnormalities do you have to average together to get an adequate signal to noise ratio. There are some other techniques that can be done using decomposition of the like ICA decomposition of the spikes, etc. That could be used for localization, but we haven't played around with any of those.
Yeah. And the consistency of the morphology of the activity would be a consideration as well, right?
Yeah, I mean, you really need to be able to have beta activity that is similar enough that you can identify reliable peaks and that the morphology is similar
Yeah.
for at least part of the ictal discharge, or that you have I think doing interictal beta localization, I would worry whether that's epileptogenic at all.
Yeah, yeah. Okay. And so what are your thoughts on using ESI in routine EEGs? And how many electrodes would you recommend?
Yeah, so I think you need to do at least the subtemporal chain. I don't
Hmm.
think that there's much utility if you don't include, F9, T9, P9 and the opposite side electrodes.
Yeah.
We are gonna, start doing more in our epilepsy monitoring unit, marking the spikes and doing electrical source localization, but we're still gonna do high density in those patients because I think we want to see what the EMU yield, the yield will be higher, but the localization may be lower. So how do those two, different locations actually influence the accuracy of the results?
Hmm. Yeah. Okay. That makes sense. Yeah.
And so
Okay.
I can't answer that question yet.
Right. Right. Okay. So stay tuned. I'll be interested to learn more about that as well.
Um,
Um,
low density source localization is still better than no source localization.
yeah. And just to clarify for the group, if someone doesn't know, the subtemporal chains that you're discussing is 25 electrodes total.
Yeah.
So the standard 10, 20, and then the additional subtemporals, two on each side, I think it is.
Great.
Three on each side. Okay. So in a practical clinical environment, how long does this whole process take to complete?
It, I could answer that. It is at this point influenced by several things. It's influenced by how many spikes people have. It takes a long time to individually mark 50 or 60 spikes. If the patient has more than one focus, that takes more time because you have to cluster everything. If they have a complex anatomy, it takes Dr. just longer to do the image segmentation and things like that. At this point, we're finding so many things that are unique that we sometimes just say, well, this is really fun, let's try to do this.
Hmm.
So that takes more time. But we've gotten it down so that we can probably do, it takes 2 hours to acquire, and we can probably do the full image and EEG review and everything in 2 or 3 hours.
Great. That's
It's
pretty
still really,
fast, actually.
I mean, it's like 10 times longer than it takes to read a routine EEG.
Yeah, yeah. 2 or 3 hours over how many people are required for that?
Oh, per person. Oh,
Oh, per person.
no, no, total time divided between me and Dr. Fuldis.
Oh, okay, okay. So 3 hours between the two of you.
Yeah.
Okay, great. And this question, the next one, excellent talk. Thank you for this information. What are your thoughts about using the lower spatial density but longer temporal sampling of entire video EEG recordings for
Yeah, I,
ESI?
I actually think that that's likely to be really helpful. It's not going to increase the accuracy of your localization spatially, but it will increase the signal to noise ratio if you have more spikes. And so, um, there's trade-offs. I
Yes.
still think it's probably better to do both, but there are some high density EEGs where you have like 3 spikes. What are you going to do with that? And it would be really nice to, we've actually gone back to some of our EMU patients and said, this is the high density result and this is the low density result for 50 spikes, and compare the two to
Yeah.
whether the high density results actually are concurrent.
That will be a very interesting study. So I think the next question is actually related, and the comment is that you only perform high density EEG for 2 hours, or do you use it for longer periods in the EMU? And this is exactly, I think, referencing that trade-off that you're talking about.
Right.
Whereas, yeah, so for high density EEG, you can have less spikes because of the high signal to noise ratio with all the spatial sampling. And if you have low density, then you need to record for longer to generate enough spikes to create a good signal to noise ratio. Is that how you would
Right, but
describe it?
I still think the spatial results are more are less reliable with low density EEG, but again, it's better than visual review only by
Yes.
far.
Yes. Okay, next question. There has been a suggestion that interictal activity has a cyclical rhythmicity over the course of days. Is there any thoughts about best way to time ESI for maximal yield? It's an interesting question.
Yeah, that is a really interesting question. I mean, we see this even in the epilepsy monitoring, or like,
Mm-hmm.
we know that seizures may occur from different places at different times, but I don't know how to figure that out for interictal recordings. It's an interesting question. I wish we knew the answer, but I don't think we do yet.
In your experience, do you think it's dependent on the individual patient, that each patient has their own unique rhythmicity, or is it something that you think is generalizable across patients?
It's probably individual. I mean,
Mhm.
data from the NeuroPace device suggests that patients have their own sort of circadian and ultradian distribution of seizures, and that
Yeah,
those are not the same for every patient. So I don't know that we'd be able to figure it out for when best to record the high density EEG. We have several
yeah.
patients that we brought back that we record seizures, record spikes, and only a few, and then we bring them back and do something else, like sleep deprive them more, or wait until they've just had a bunch of seizures and then try to do the high density EEG. But we don't have any standard method of trying to record different
Trying to
types of.
time it. Yeah,
Yeah.
okay. What's the current state on ictal ESI for posterior quadrant epilepsies, as interictal often fails on these due to lack of spikes?
Yeah, I mean, it really depends on how often you record seizures. We've been doing this for in a real way for about a year.
Hmm.
And we have 85 patients. And of those, I think we've seen 10 patients with seizures. I'd have to go back and actually figure it out. So it's not unheard of, but it's certainly not common enough. And you need to have patients who have pretty frequent seizures to hope that you're going to get seizures during the study.
You mean that you have 85 patients with the posterior quadrant epilepsies?
Oh, no, no, not posterior quadrant, 85 patients total with
Total. Okay, and 10 of them had seizures during the EEG recordings.
just
Is that
about.
okay? Yeah, that makes sense.
Um,
Okay.
but certainly you could do this for the epilepsy monitoring unit, as long as their seizures are fairly stereotyped and stable at onset. You could do a low density EEG based on the results of epilepsy monitoring unit
Yeah.
seizures.
Yeah. Yeah. Okay. So you mentioned that there needs to be a certain number of people doing the procedure similarly before a new CPT code can be made. So what standards are they looking for to consider the approaches to be similar?
So that we agree on what steps should be done,
Hmm.
in terms of how much, so what you really need to do is determine the time similarly across different things. So what if someone just uses a template model? Well, that's really simple because they don't really do MRI analysis. And so the time might be, decreased by a third. So we should define what we mean by ESI in,
Hmm.
low
In a
density,
practical way,
high
yeah.
density, individual head models versus template models, those kinds of things. And then we can determine how much time it takes for that. And that is what is needed for to develop a new CPT code. So anyone who does any ESI at all and wants to do more or participate in a group that would define standards, please send everyone who's on this call my email, and they can email me.
That's a great point. How can people find your email, your contact information?
Oh, I'll send it to you, Marie, and you can just email everyone.
Is that okay? We do
Yeah,
send out the link to the recording, so I'll include your email address for those that want to
yeah,
participate in
yeah,
something
as
like
long as
that.
they're here. And I'll ask you guys not to like send it to anyone inappropriate.
Yeah, that's right. Only this group. Okay, perfect. Yeah, that would be very interesting. Um, and then I actually had a comment. You had a case study where the ESI actually led you to discover an epileptogenic lesion on the MRI. And that's actually not the first time that I've heard that from you, which I think is really interesting. And in both cases, if I remember, it was high density EEG that led you to discover those kinds of lesions. What are your thoughts on ESI as a way to turn MRI normal patients into patients that have identifiable lesions? Do you think there's any kind of practical application for that sort of thing? And also, how
I,
many are
I
those?
mean, I think that's been done even with routine EEG, right? People are
Mhm.
like, oh yeah, let's look more carefully in the MRI in the left temporal lobe, right? And we find it. But we've had, I don't know, probably 4 or 5 cases where we found lesions on MRI because we go back, make the radiologist go back after we do the high density EEG and look really carefully at this region, using a high resolution MRI. So it's not uncommon.
Yeah, yeah. Okay.
One of the advantages, I think, to this technique, but you can sometimes do it even with standard.
Yeah. Okay, wonderful. And then there's a couple other comments. For people who don't have access to a 3D localizer for the localization of the 3D positions of the electrodes on the scalp, you can actually do this if you co-register. You can co-register the electrodes in an MRI. So
Yeah.
the comment is template electrode set could be used and co-registered with individual patient MRIs. And so then you have the electrodes appearing on the MRI, which is then used in the forward solution.
Well, right, but then you have to use MRI compatible electrode for
Right, that's the caveat
themselves. Then
there.
you have to
Yeah.
get a special MRI with the high density EEG, which increases the expense of the entire study and it increases the complexity of the recording and blah blah blah. So we've done that in some patients who have MRI while they're doing inpatient monitoring in the intensive care unit.
Hmm.
Gotten some patients that happen to have an MRI while they have their EEG electrodes on, and we've used those locations for co-registration, but we don't routinely do it for a high density EEG. We just localize by anatomical landmarks.
That makes a lot of sense. Yeah. And then, often a point of discussion, whether or not you have the 3D positions of the electrodes to incorporate into the patient's head model. And there's really only one publication that I know of that discusses it, and it's from 2014. Maybe you know of some more that we can include. I can send it out in the email that goes along with this, but that one was done using beamformer in a simulation, and it was a pretty good study, and it did show, the margin of error in the localization of the activity if you have the position of the electrodes incorrect by however many millimeters. So that I think is worth sharing with the group, but I wonder if you know of any other publications that discuss the importance of the electrode positions.
Not yet, but there may be.
Ah, okay, okay, good. Again, stay tuned. Great. And then there was another question about where to get the high density EEG caps. Um, and I think what I'll do there, Dr. Herman, maybe we can collate a list of vendors and just include that in the email that we send out to the group rather than try to name them all here.
Yeah, I think that's fair.
Okay, great. So then that's it, everybody. And thank you very much for attending. And thank you, Dr. Herman, for the excellent talk.
Thank you very much.
Okay, bye-bye.
Bye.